Yeah, sure. Thanks, Steve. Good evening, everybody. Thanks for joining us again on another lovely Wednesday evening. Fireworks night tomorrow. We were just wondering how many of us are going to be out there setting up fireworks, because nobody can attend any bonfire nights, can we? So we were just thinking about buying some dodgy Chinese fireworks and having a party. We all dial in by Zoom, show off each other's fancy array. So yeah, it's just question and answers this evening. We've got a bunch of slides to go through if the conversation's a bit light to begin with. And what we thought is we'll just put some questions out there. So perhaps what we'll do is put a slide up and let you guys have a little look and think for a second. And then maybe if anybody fancies trying to describe what they're seeing on the screen, that might be useful, because in future, you've got to get used to using language and terminology. So Adrian and I will be here to help you out. And if it looks a bit bumpy, then we'll interject and say what we see, because of course it is very unique and individual and independent. There is no right and wrong. Literally you just got to look, see and say exactly what's on the screen in front of you. So we all do it differently. Looking at reports from various sonographers and radiologists and everybody else who does it, no two are the same. So no rights and no wrongs. It's just say what you see, Tom. So don't be shy and try to jump in. At the same time, I have got the scanner set up here in clinic today. I don't have any company from Adrian, but I've got 2 willing feet of my own and a couple of knees and even a shoulder if need be. So if anyone fancies, having some live scanning and there's any particular structures you want us to try and look at, I will try and do my best to facilitate that. And I think we'll just start off by just opening it up to everybody. Is there any burning questions to begin with that anyone would like to ask Adrian or myself? Over to you guys.
I'll see if any come in on the chat. I have got a couple to jump to straight away. We got any? I've sent them to my iPad, so I can still don't have to go off the computer. Upstairs for thinking. Glossary. Okay. Are there any? Where would you find any glossaries, basic but commonly used terms? Any suggestions on that, where they might go for some resources for commonly?
Oh yeah, when I first started out, that's exactly the kind of things I was looking out for. I hit Dr. Google, started my search there, as most of us probably do these days. And there's a whole bunch of stuff out there. A lot of it's American. From what I've read, that's available easily on the internet. I think Adrian probably knows a couple of specific resources. Or there's one, I think there's ultrasoundterminology.net. Don't quote me on that completely, but that rings a little bell. There's a couple of sites out there with specifics. You can just
yeah, there was a good website called Sono World. But that's just recently been taken over, and it's changed somewhat. And they had a whole chapter on glossary, and it just gave all the ultrasound glossary for loads of things. But I don't think that's there anymore.
A few of the textbooks, I think I've read them in. Ultrasound textbooks. There's several out there. Sorry, I haven't got any authors to mind. I did have one on the shelf somewhere.
Yeah.
So you probably find a glossary of terms in a lot of the textbooks too. When the course that we do for the Institute, I do actually do a little module on ultrasound terminology. So if anybody fancied that in future, that's part of the course material. It's multiple choice questions, and the theoretical part split into several chunks. And we do cover and give you all the terminology info there. Maybe I can dig it out somewhere at some point and maybe email it over to Steve for you.
That'd be great, thank you. Yeah, and I'll happily share that out for those that would like that. Yeah, and it's a key thing, isn't it? Particularly for people starting out, you really just want to make sure you got the terminology and so forth, and it's that's a good thing. Okay, what else have I got? Okay, some top tips for picking places to do a PG cert. The questioner has said here you might not want to recommend anyone, but any thoughts on that? If somebody looking to do a PG cert, any experience?
Yeah, plenty of good ones around. I think Coventry do one, Birmingham do one, and then we got the great guys down at Bournemouth.
Yeah.
I'm not sure that they don't give you a PG cert directly, but then you can upgrade that certification. I think you get from there with the local university, which is where are they again? Southampton, is it? Part of Southampton, Bournemouth, part of Bournemouth University. And I think you can upgrade there to a PG cert, a PG dip, or even a master's.
Yeah. I did mine in Cumbria. There's only Cumbria and Bournemouth when I was doing it, but I know they're doing one in Cumbria. But I think there's one at Paola will know this because she does it with the Dr. Estaghini. I think he does one.
Yeah, that'd be the Queen Mary.
Oh yes, okay.
Yeah. Was it Myland or Queen Mary?
Yeah.
Yeah.
Yeah. So there's a lot more out there than there was, certainly.
Uni of East London, yeah. Myland.
Which is good. That's what we want. You know, it should be readily and easily accessible to all. That's the good thing about it. The more the merrier with ultrasound, I think. Actually,
and Peter Estaghini getting mentioned, talking about the earlier question, and he's happy for us to share this. He's happy for me to share this. You go on his website, MSK US, and he's got some really good resources on there, particular parts of the different structures of the body of some kind of pitfalls and things to look at. And he's more than happy to share. I was with him on a cadaver course in September, and he said I was more than happy to share that out. It's not copyright or anything, so he's happy with that. So that's another really good resource, and he's a top guy. That guy knows his onions. So so that was about the question.
Yeah, and there's plenty of really good resources on the usual, YouTube and whatnot. If you haven't already had a look, just ultrasound ankle, ultrasound foot, ultrasound Mortons, ultrasound shoulder. There's plenty of learning resources, easily accessible. You don't have to be, tied up in members of all sorts of organisations. There's plenty of material out there, and a lot, is provided directly by the ultrasound companies too. Don't forget, Celtic SMR, of course, are doing an absolutely sterling job of providing very, very valuable healthcare resources to the public and professionals. But there are others too.
Is there?
Do I get a brown envelope for that plug, guys?
You do.
Thank you.
Apparently, there are other companies out there.
Nudge, nudge, wink, wink. Yeah. No, but really, yeah.
We're going to be jumping around here, so that's great. We had a couple of questions just to get us going there on the resources side of things. So one or two people joining us, but let's get. I've got one or two more clinical questions as well coming in. Hi, Sean. Good to see you. Good evening. How can differentiate between a neuroma interdigital bursa?
I'm happy to take that if you want to, Abid.
Sorry, I didn't catch the end bit. Sorry, Steve. Cut out a little bit there.
How can you differentiate between a neuroma and an interdigital bursa?
I've seen reporting and jumping way after Adrian over the years where there's very specific differentiation between a Mortons and a bursa, and I think it really just boils down to the skill of the sonographer. Because of course these days the terminology is altered very slightly, and we tend to describe them as because they are very difficult to differentiate unless you're very, very skilled at it. I think now we tend to term it, bundle it together, and we call them a Mortons bursal complex.
Yeah,
maybe a bit of a cheating way to do it, but it is difficult. I personally have found Mortons neuroma as one of the most difficult things to scan in the foot. Everybody again does it very differently, and in the future we'll show you a bunch of different techniques. But I suppose ultimately one would be a little bit more squishy than the other one. A Mortons would tend to be a solid mass. You're not going to be able to compress it, and it will generally pop up and over the met heads as you apply the coronal compression. On the course, we show a few techniques where you use the probe to dorsiflex the metatarsal head so you can get them in a nice linear row. And then from there, you can apply your metatarsal compression, and you can actually see a Morton's sign. You'll actually see the neuroma pushing up and over in between the metatarsal heads. Whereas a bursa, I suppose, correct me if I'm wrong, Adrian, but with lateral compression or coronal compression, You'd expect to see it squishing and bulging up and down a little bit maybe, but it's certainly not likely to jump up and over. A few other features, maybe you get a little bit of vascularity in there possibly.
Essentially, yeah. I mean, I'd always squeeze the area, and a bursa you'll tend to squeeze around it, and it'll stay fixed. It'll be probably mixed echogenicity as well. It won't be purely. It'll be dark, but it won't be purely anechoic, which is black. And a bursa will probably tend to be more anechoic and black, and you can squish it and it'll squish down. But as Abid says, they usually come together, and that's why we term them neuroma bursal complexes. So you might get one where you squish down, and some of it will go away, and some of it won't, and then absolutely that's the neuroma bursal complex. But essentially, if you've got a black hole and you can compress and it goes away, then that's more likely to be an intermetatarsal bursa.
And don't forget, you also get the plantar plate bursas. You know, they show up too, not just the interdigital ones, and a little bit more easy to identify a plantar bursa perhaps than an interdigital one, in compared with neuroma. And you should, you know, always look out under the plantar plates for plantar bursas. They're definitely out there. You do see quite common, do you think, Adrian?
Well,
those submetatarsal bursas.
I've not seen many, to be honest, but then you probably see more than me because you're doing probably more feet and things like that.
Not the most common thing for sure, but they're out there.
Yeah, sure.
Oh, okay. Thank you, Sean, for the question. Okay, and next one I have is from Peter. Hi, Peter. Nice to see you. Thanks for joining us. I would like to be able, this is from Peter, I would like to be able to measure the thickness of the plantar fascia. What is the normal and what is pathological?
Well,
you want to do that one, Adrian?
Yeah, sure. I mean, I'd call normal up to 4 millimeters, and anything above 4 millimeters, I'd probably call pathological. But then I'd probably compare it with the other side, always compare with the other side, unless they've got obviously bilateral plantar fasciopathy, and then you've got to be a bit more careful. But it's essentially compare it with the other side, and if it's above 4, then it's probably pathological.
Yeah, it's just dependent on the individual, but yeah, 2 to 3 millimeters is considered normal limits. And anything over that could be, but compare with the other side, always, absolutely. Also, got to scan across from medial to lateral and try and look at the 3 branches, perhaps, and look at them independently, because sometimes you'll see something pathological on the central branch, but not on the medial branch, and vice versa. So always check a little scan across the base of the heel to have a look at that. It also depends, I think, on the height and foot type of the patient. If they're more cavoid type foot, I think you tend to generally see a slightly more thickened fascia anyway. It's just tougher because it's been, you know, in that cavoid, getting a lot more impact. So the type of foot and the size of the patient, and also, what was the other point? Completely gone out of my head.
While you're thinking of that, then, would you typically, if you're measuring, if you're looking for that kind of measurement, do you do left and right to compare this for the patients?
Yeah, you got to, because what's normal for one individual? I think I've never seen anybody really in a normal foot anything over 5 millimeters thinking about it, but you can see sort of 5 millimeters and a little bit over perhaps, and it can be normal and not pathological at all. You know, people who are on hard floors a lot, factory floors and stuff, you know, hard workers, you know, been doing manual work perhaps for a lot of years, you might expect to see a slightly more thickened fascia there, or even a more irregular plantar heel bone. You know, the surface of it usually is very nice and linear, nice and round and curved, and often in people who have been on the feet working a lot, you'll see you know, sort of jagged edges around the bottom of the calf, just showing that they've, you know, had a lot of wear over the years. Quite interesting to see. You can get calcific deposits within the fascia, potentially. Of course, you can get rips and tears, linear and transverse, you do see them. Sometimes you see them with the plantar fascia with no vascularity at all, just the thickening of the plantar fascia. You can get plantar fasciosis now, as we call it, isn't it? It's more commonly used. You can get, sometimes you see a heck of a lot of vascularity in there. Have you seen cases like that? Really inflamed, swollen. You put the Doppler on there, it's just Christmas lights going off. You could worry, and it could be a sign of a tear in there potentially. Yeah, so if you're thinking about doing an injection, always put your colour flow on there and see if there's any vascularity. If there is a lot of activity there, you might want to double think and try and double check for a potential tear before you considered an injection, for example.
And also don't forget to sort of do your sort of dynamic assessment as well. So move your foot about and you'll see little subtle tears sort of open up and things like that.
And don't forget to check your attachment and insertion around the into the Achilles as well. Got to get around the heel bone because you can get enthesitis. Do you want to mention a bit about what you see? You report a fair bit on enthesitis, I think, Adrian. Again, it's dependent on the skill of the individual as to whether or not they'll pick it up.
Yeah, just you might get little bony irregularities, pull-offs from the insertion. And then thickening around, and that's just sort of turned enthesopathy. So you can obviously comment on that. A good trick actually with when you're looking at these is obviously your heel pad's going to be quite thick, so you probably want to go down on your frequency a little bit. You'll probably find with your normal setting on your frequency of the probe, you might think, oh God, I'm not seeing anything. But don't forget, your ultrasound's struggling to get through, so take your frequency down. Get through to see the tissues, and then you can also alter the dynamic range. You'll have a button or a setting on your system called dynamic range, and that just alters the grayscale. When you alter the grayscale, it'll tend to define little borders a little bit better. So if you're looking for little subtle tears and the borders of your fascia and things like that, then altering the dynamic range can really help you with that.
It's also ever so useful to know when it's not a case of plantar fasciitis. I've had numerous patients referred for, assumed plantar fasciitis, and they've had all the usual stuff chucked at it, bells and whistles a lot, and it's not responded whatsoever to treatment. And they've sent it over for possible injection or whatever other reason that gets referred to us. And when we scan them, we can find that there's actually no evidence at all of any plantar fasciitis there. And don't forget, of course, there's several other conditions that can cause it an effect and give you heel pain. So again, it's really useful for process elimination. I can't count the number of times I've looked at it for a referral for plantar fasciitis and told them very clearly, definitely you ain't got plantar fasciitis, something else going on. And then from there, I'll go and check, Achilles insertion, or quite commonly I find the subtalar joint is affected. Don't forget, it's another very, very busy joint and tends to get degenerative changes and arthritis, and I think they just get stuck as well. There's some, they do get just compressed. You just find that they've not got that usual inversion, eversion, and then of course there's all the local tendons around there, and fat pad syndromes we do see quite a bit. I've definitely seen more fat pad syndromes than I expected to. You can see what's going on in the heel pad very nicely. And then of course then you've got to start looking deeper into the you might need to think about other imaging then, x-ray, MRI, etc. You can get osteochondral defects, you can get necrosis, you can get 101 other types of problems, but knowing when it's not plantar fasciitis is also incredibly useful.
Brilliant. Okay,
I'm waffling.
And just to round that question, the answer off for you there, Peter, I know you're trialing one of the scanners. Are you happy with how to measure with the calipers on the unit? If not, we can put a technical. I can get a colleague to phone you in the next couple of days, and we can talk you through that as well if you want us to.
Yeah, that could be really useful. Thanks. I haven't attempted that yet.
No problem. We'll talk you through that as a 5-10 minute phone call. No problem.
Okay, thanks.
On that, no problem. Thank you, Peter, for the question. Okay, next one, Martin. Good evening, Martin. When you're using Doppler, how do you know if the sensitivity, i.e. PRF, is set at the appropriate level and you are not exaggerating the amount of flow? Did you get that?
Yeah, so what you've got to do here is go to somewhere and find a vessel and basically mess around with the PRF until you've got so you're picking up the flow of the vessel, and then you can do this by just turning the gain right up until it's completely blaring out and aliasing your image, and then slowly tweak it down until it goes all the way, and all you've got left is just your vessel, and that's how you set your Doppler settings or your color flow settings, and then obviously put it over the area that you're looking at, and that should be fine. That makes sense.
Got the thumbs up from Martin. Yeah, it does. Thank you very much. Not a question, but a contribution here from Sam. Hi, Sam. Good evening. A regular attendee and contributor. Thank you. I've actually put a link on here. I haven't opened that up yet, but that must be in connection to the very first question regards glossary that she uses. So thank you for sharing that, Sam. And that's gone to everyone. So can you all, if you want to pull that off, guys, feel free to copy and paste. Well, obviously not feel free, do it. Help yourself, copy and paste that. So I'm sure, knowing Sam, that will be a really useful piece of information. So I'm going to recommend that without even seeing it myself. Paula has confirmed, yeah, Uni of East London. Was that to do with Peter Rustaghini? Was that in response? Okay, more questions. Hi, Abid and Adrian. Can you describe what you see with the heel fat pad issues with a normal plantar fascia? Might have covered that already, but just.
Yeah, so you tend to see the adipose tissue layer sort of develop anechoic areas within. You know, you tend to get separation between the fat sort of modules, if you will, and you can just see a general thinning of the fat pad structure, and also a separation of the actual fat cells. So you've almost kind of got gaps, if you will, in there. Yeah, sometimes again you can get some kind of vascular changes in there. Yeah, but again, it's looking at the plantar fascia and seeing that that's normal. And then with whatever's left, don't forget, apply some probe pressure, and you'll see that you'll have kind of movement and loss of sort of density of the fat pad. Any other features you see, Adrian?
No, I think you described it pretty well there. Just quite sort of hyperechoic and almost like fluid-like within the superficial tissues and things like that. And
yeah, it's just not that nice, dense, usual layer that you'd expect to see. It's just looks much more separated out.
I should have said that was from Chris. Good evening, Chris. Chris is a loyal follower of ours, so always joining us again. I think that's all the questions I've got at the moment on the floor. Oh no, here we go. Just in time, Elaine. Good evening, Elaine. Didn't see Elaine sneak in there. How thick is a normal fat pad?
That's varied. That's very varied. Yeah, I reckon at least 4 or 5 mil thickness, maybe minimum. Hard to say. I've not seen any specific numbers on that.
No, I mean you can certainly also. I've seen thinning over the metatarsal heads quite a bit, and where they've got pain on the metatarsal heads, and then you just scan it from underneath, and you can see that the thickness is so thin, the bone's almost touching the floor, so you can sort of mention that you've got sort of thinning to the fat pad, certainly on the underside by the metatarsal heads.
Atrophic changes in the fat pad is a common sort of term you hear.
Yeah.
Okay, brilliant. Thank you. I hope I answered that for you, Elaine. What have we got here? Maurizio. Hi, Maurizio. I hope I've pronounced that correctly. When assessing plantar plate tears, we're on a roll here with plantars, aren't we? When assessing plate tears, how do you confirm that there is a tear?
You've probably got to try and physically gap the tendon a little bit and see if there's degree of separation. Adrian, is that what you do?
You sort of hyperextend the toe back, and it causes a bit of pain, but you can sort of see a bit of gapping there, and you're just looking for that hyperechoic, like a little triangle defect in the plantar plate there, and certainly sort of hyperextending those toes back will tend to accentuate that a little bit.
You've got to get right in there into the area. And tendons is interesting. If we don't get a chance to cover them in great detail today, I think that's one good program just on different tendons. And actually, it's so interesting to see the different types of tears that you see in Achilles tendons. You know, I don't know about Adrian, but I've never seen two quite the same.
No.
They're all very unique.
Just on a side note to that, actually, if you want to confirm that there's a tear, then one thing that you should always be doing is confirming it in the other plane. So turn the probe in the transverse or whichever plane you've got it in, turn it in the opposite plane and confirm it in that plane. So if you see a hypocoat defect in the transverse plane, then turn your probe longitudinal. And if you can find the triangle defect in that plane as well, then it's a good chance that that's confirming that there's a tear there.
Okay, thank you. I'm getting questions coming in with all angles, so this is
nice. We like it. Lots of interactivity this evening.
Just bear with the tumbleweed in between. Okay, here we go. Another one here from Chris. Thank you. I have seen an image of a thin line of probable calcification in the Achilles paratendon.
Yeah.
Deep 0.5 millimeters deep, 1.5 centimeter long. Oh, sorry, half a mil, yeah, 1 centimeter long. Is this a rare finding, mid-tendon? Did you get that?
Yeah, just looking at it. No, you do see them. I mean, today I had a patient who sort of osteoneogenesis or something, and it's the first time I've seen. I think you scanned it actually, Adrian. Absolute whopping calcifications. Bang in the middle of the tendons.
Oh yeah.
Yeah, it was only a few weeks back. Absolutely humongous. They look like mushroom clouds.
Oh, okay. Yeah.
Yeah, absolute massive stonking right in the middle of both of her tendons. It was an interesting story. She'd 10 years of history of symptoms, bilateral Achilles tendons, and she's a keen runner and athlete and all the other things. And she's absolutely exhausted every private podiatrist, physio, this, that, and the other, and anybody else there is to try and help in the whole area, and not been able to move forward. So when we scanned her, we found these whopper. You know, never seen them that big. You know, just floating right in the middle of the tendon.
Yeah.
There was thickening in the tendon around it with a little bit of mild vascularity. Otherwise, just it was probably measuring about the size that Chris mentioned there, 0.5 by 1.5, right in the middle. Calcification in the paratendon. I've seen it in the mid-substance of Achilles, for sure. You do get, you can get linear changes, get a lot of calcific changes. On some of the slides we had to show you, there's quite a few actually calcifications, but I don't know if I've personally seen one in the paratendon. No. Did you look at it? I suppose you got to go on. Hopefully, went transverse on it. I suppose that's the only way to really pick that one up. Hard to figure it just in long axis. But I'd be very interested to see the picture. If you got it to hand, maybe you could just put it up for us. We can talk through it anytime you wish. Yeah.
Along next time.
Yeah. Sorry, Abid, I lost you there. Yeah, it's a real strange one. This fella had a torn Achilles, and between when I first assessed him and reviewed him was about 4 weeks. And in the interim, this had developed within the paratendon itself. Quite a very, very thin line, let's say about 1 centimeter length. It was invisible in both planes, and it was definitely not within the tendon. It was definitely like a line on the surface. Yeah, quite interesting to see it develop.
Gouty thing? Any evidence of that? Was there vascularity around there at all?
There wasn't, no, but quite a bit of trauma, quite an older patient, so there may have been some kind of background issues with that.
Yeah. Could be. That's the funny thing about ultrasound. You see the most weird and wonderful things all day in, day out, So, yeah, absolutely. Could be. Be very interesting to see.
Yeah.
Okay. I know it's just...
How about you, Adrian? Have you seen any calcification in the paratendon on any tendon?
No, I don't. I don't think I have, to be honest.
Any idea what that could be?
No. I don't know. I've not seen it in the paratendon, Tendon. There's no.
I have seen paratendonitis. I mean, you get that anechoic sort of layer in between them. So you see plenty of dark ones. You do see plenty of tendon sheath issues.
Yeah.
But yeah, I don't know whether or not it's picking up an artifact, maybe.
Well, not if
But you said you scanned it in both planes, didn't you? So it tends to be dark anyway. If it wouldn't be bright white. Actually thinking out loud.
Yeah.
Interesting. Yeah, bring the pics. Be good to talk about that.
Yeah.
Brilliant. Thank you, Chris. And then Hannah said, got a foot that I think is a plantar plate tear. Can I share it? Yeah.
Yeah, please. Yeah. Let's have a look. Yeah.
All right, I'll have a try sharing the screen. This is me taking a photo of the scanner.
Okay, cool. Yeah, I do that. Yeah. Do whatever way you can.
I haven't yet, so I think otherwise I can. Oh, hang on. Let's see how this works. Screen. Now, all right. Let's try this, but it might not work. Oh, do you know, I might have to find some other way of sharing it. I can't figure out how to share a screen with Zoom. I'm really sorry.
Oh, the little green button. Click on there and then...
Just hover down below all the thumbnails. You should get a green button come up.
Hang on, then I can just press share. No, it wants to do... Oh, hang on, yeah.
You'll still have it on your scanner, the photos, the pictures on its scanner, isn't it? So you probably won't be
no, I have to quit. Don't worry, I have to quit to be able to do it. Just when you were talking about the triangle, I was like, oh, I happened to scan a friend's foot just to practice.
Yeah.
And she had this sort of real hyperextended second toe. And when I took a video of it, I was like, whoa, that really goes a long way. And I was just looking at it thinking, oh, it had that exact dark triangle you're talking about.
Yeah, no, that's cool. That's a great point though, Hannah, that, anybody who's got images, this should be that type of a platform where we can just share and look at each other and learn from each other's work. So don't be shy.
Here's a suggestion. And if you want to send that to me over the next couple of weeks, we can talk about it on the next webinar, if you like, in 2 weeks' time. But we can give us a bit of space.
Oh, there we are. Does that work?
Oh, look at that.
Okay. Yeah. Yeah, I see what you're saying there. Yeah.
So like that little.
If everybody pins video on Hannah, you'll see it in
that could be normal as well. That's hard to say just on one static image. You might just be picking up that little bit of artifact underneath from bouncing off the bone. You see how the bone's very bright white there. But yeah, it could be. I suppose you just got to scan a little bit medial to lateral and just see if you can reduce some of the signal around the bone, reduce the what's it called? Thingy a little bit again.
I hope Hannah doesn't mind.
What do you think there, Adrian? Do you think that was a obvious plantar plate tear?
Well, it looked quite.
It does look like that sort of thing, doesn't it? But yeah, well, you're on the right track at least, definitely.
Yeah.
It totally could be.
Right range of motion for it.
You just got to kind of zoom in on it a little bit, zoom out, zoom in. Just look at it in the different planes and just inspect it. If you're really kind of scanning along and suddenly think, oh, hang on, that could be something there. And then from that point, you just got to spend a few minutes just checking it out, wiggle your probe around, go around and around as much as you like, and try to confirm in your own mind. And then, like we were saying earlier, just try to dorsiflex a little bit and see if you can gap it. So you just got to really interrogate it. Once the suspicion's there, just interrogate away. Yeah, that's cool. Could well be.
I'll say, I'm sure Hannah won't mind. Well, I hope Hannah doesn't mind me saying that it was Hannah that asked the question about the PG cert at the start. So I think you're a bit of a natural there. So I'd get on that course as quick as you can.
Good skills. Yeah, it's a really good image. Otherwise, you got all the right structures in place and everything was showing up really nice. So good pick.
Thank you.
You're welcome.
Thank you, Hannah. Thanks for that contribution. That's great.
Better than some of mine.
What, sorry?
Better than some of mine. quite textbook, really.
Okay, right. I've not got any questions. I don't think I have. I missed any? I don't think so. I will go to my bank of questions. This is an interesting question and potentially controversial. So, how can you monetize the machine training? How can you make the investment work hard when compared with, for example, laser? Quite right, great idea. Shockwave, never heard of it, and Swift. Swift, for those of you who are not podiatrists, that's a very popular machine for verrucas, treating verrucas. So the question is, obviously there are modalities out there where people can monetize it and there's a return on investment. But how would you propose you do that in the scanning world?
So you just got to look at any other treatment that you provide. You know, how much time, effort, training it's cost you. You know, how much the machine has cost you. It's a decent sum of money. All the effort and years you put in, and it's hard to put a monetary value on that. But then you've got to, you've also got to think at the same time, what if I wasn't performing this scan for this person right here, right now, where else would they be able to go in a timely fashion for a decent sum of money to get a scan, where actually if they did go somewhere else just for an independent scan, and no offense intended, Adrian, you essentially go to see a sonographer, who would do a scan and do a very nice report, and then send that back to somebody else for them to action. So you've got these long time delays in between, from referral to actual scan, and then from scan to coming back to the clinician. So how much what's the value of that worth? So there's so many little facets to think about. But ultimately, you've spent a heck of a lot of money on this machine, and you're providing a very good service, and you're giving a diagnosis. People spend a lot of money on imaging. If I refer to a local hospital for an ultrasound scan, you're going to pay anything from, depending on where you've gone, from 150 to 350 quid. Of course, you might be paying, a consultant radiologist to do it, but, if you're skilled enough, and also you're going to be providing treatment, so you're giving a diagnostic scan in a timely manner, in a safe, controlled environment, blah, 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 bells and whistles attached. I would think about how much you charge your normal prices for your consultation or treatment, whatever, and then you got to charge something for it. So when I started, I charged my normal consultation is £99, and if I did an ultrasound scan within that consultation, I charged £70 on top of the consultation, and that was not including a report. If they wanted a full diagnostic report with that would cost £150. So and then the other good thing about it is you can offset it. So people might, but okay, well, where else are you going to go for that little money to get a diagnostic scan? Point number one. The second point is you're probably going to end up seeing that patient back again. And the thing about ultrasound scanning is it's great to go and have the pictures and image and initial diagnosis, but it's even better if the patient can come back and have a repeat scan in 4 to 6 weeks or 8 weeks or 3 months or whatever it is that you dictate. So, what's that worth? Again, if you were going back to NHS, you'd have to have another referral. You'd have to chase your GP for another referral to get you another scan. And then the radiologist is going to look at, well, you've already had one scan. Why do you need another, And if you sent privately for another referral to your local BMI or Nuffield or whatever, then you're spending another 350 quid. So I think there's more than enough to justify your cost. It's just being confident in your skill and ability. And initially you might want to just do an odd free one here or a free one there, or you do the first scan and you charge for it, but the second time they come back, you won't charge a second time for it. So there's so many different ways of figuring it out, but ultimately it's a very, very valuable tool, and it's used as a medical aid, and it is a diagnostic scan. It's very, very powerful and valuable, so you've got to charge for it, and you shouldn't feel, I don't think you should feel any shame in putting a money value on that. That is providing a service, and, everything costs something. So, there's a lot of benefits to it. So if they moan about the price, well, all right, go and see your GP then, and he'll refer you for a scan, see how you get on. Especially during this time, look at this COVID crisis. We're providing such a great service to be able to, see, assess, scan, and a lot of times treat at the same time. You know, all in a one-stop shop. You know, what value can you put on that? You can't get that in NHS land. There is no one-stop shop type setup or service that I've seen. Yeah, we do try. Yeah, but what the heck, you know? You know, and interestingly, I was having this conversation with a colleague of mine today, David Singleton, podiatrist that works with me in NHS. And there's a lot going on. I'm sure you're all aware about FCP, first contact practitioners, been out the front line. A lot of physios been training, upskilled and whatnot. And, you know, these guys are a little bit tetchy and worried because they might end up seeing cancers and this and that and all sorts of other things. And there were a bunch of interviews today for new FCP practitioners. And a lot of them were internal and had long NHS service. And, you know, we talked about how well they'd performed in the interviews. And there was one person that came from private practice, only one, a band 5. And interestingly, that person's knowledge and skills and information was way above and beyond a whole bunch of long service band 7 and 8s. Yeah, so I think we get sometimes underlooked and undervalued in private practice, but actually there's a lot of very, very clever people out there in private practice, you know, a lot of skills, and they are essentially in our brains, you know, first contact practitioners and always have been. You know, you can see absolutely anything coming through your door. You don't know what's going to walk in next. It could be something cancerous, it could be something very nasty, it could be something simple. You know, but we've effectively been doing that since day dot. You know, it's just that they've put a label on it now and they're, you know, upskilling in other ways. But you know, that's just my little rant on that bit. But yeah, you know, I applaud private practitioners. You know, I've been trying to get so many services set up in NHS for so long, and you know, they're absolute no-brainers. We do this, and this. We save money or increase. Benefit to the patient, or you know, services better and all these things, but time and time again you're just frustrated. Hence why myself, you know, after 15 odd years of frustration in NHS, decided to set up in private practice just out of frustration of what I couldn't offer my patients in NHS land. You know, and it is a whole different game, and I've come to find that you know, other like-minded private practitioners equally gifted and talented, and a lot of the time go above and beyond a lot of the skill sets of NHS practitioners. I'm allowed to say this sort of stuff. I hope I'm not offending anybody.
You're getting applause.
I'm trying to big up the private practice crew. Yeah, but FCP thing is what we do. That's what we are anyway.
You're getting support from the audience for sure. Abid applauds. Paula agrees. A couple of comments coming in about the CQC though, with regards to that. So obviously, being registered CQC from a charging point of view, is that the typical understanding?
Oh, CQC is a big headache. I've been just going through that with Adrian's got first-hand experience. I believe he's one of the only and probably the first sonographers around that's independently become CQC registered, so he can tell you more about that than anybody else. I myself have had dealings with CQC over the last few years with my other hat on with the Institute, you know, and trying to get our own premises CQC registered and looking at other private practices. So it's a humongous paper exercise. You know, the documentation is about this thick. You know, it's like you're going to send a spacecraft to the moon or something. But yeah, we're not on that radar yet as podiatrists. So, you know, whilst we can maybe push it a little bit more before at some point, I'm sure undoubtedly at some point in future we'll come under that sort of regulation. But at the moment, there is, you know, it's about just being sensible. It's a part of your own practice. It's just about recording. So you've just got to look at how you're going to keep your images if you're going to, you know, how you're going to store them if you're going to, are you going to give them to your patient, how are you going to keep your records and reporting. Most of us have already got these robust systems in place for storing your patient records. So it shouldn't be a great deal to add more to it. Whether or not you do store images at all, I mean, but the other way to look at it is it's part of your clinical remit. So do you have to store an image at all? Is it enough to just have a report? You know, as long as you've said what you've said, you know, you looked at the scan, you said at the time I saw, you know, fusiform thickening of the Achilles tendon, there was mild vascularity or whatever, and you've documented that thoroughly in your records. Is that enough? Do you have to have an image recorded with that? It's just a grey area. For as a clinical use, you know, if you're a sonographer, then different set of rules apply. But you know, how many times we're in working away in orthopedics, and you know, I don't know, I think that guy might have a problem with his Achilles. Oh, well, we've got an ultrasound sitting in the corner there, one of those handheld ones. Why don't we just pull it out and have a look? And yeah, all right, yeah, okay. Well, it's this and this and this. We just reported it. We didn't record the image or take pictures or anything. We just kind of, you know, as clinicians, we've used it to reinforce what we clinically suspect anyway. So you could say, you know, very, very tender Achilles palpation, you know, appears swollen and feels full and thickened. Under ultrasound interrogation, I could see, you know, the fusiform thickening, the swelling, blah, 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 whatever you describe. And maybe that's enough. You know, you don't actually necessarily have to keep, capture and store images, because that's a whole different kettle of fish. If you've got the right recording system for it, great. If not, you know, it's also a time-saving thing, isn't it? You know, wherever we can to save minutes and seconds. What's your take, Adrian? Because you look at it a bit differently from my clinical you know, practitioner view.
I mean, certainly for sonographers, I mean, we just can't do anything without having that CQC registration, and you need to, you know, if you're documenting a report, then you need to have that image evidence, and you need to have obviously all the patient details stored in 9 years, I think it is, and that's, you know, and they all have to be stored in the UK as well. So you can't have storage outside the UK. So I mean, it's governed by the Royal College of Radiologists, and they've stipulated what has to be done. But as I said, I don't know what it is for you guys. I mean, if you're writing a report off an ultrasound, I mean, for me, they've said, you know, if you're writing a report, then you need to be documenting images. I mean, it's only going to be an issue if something comes up in court. That's what the big thing is. If it comes up in court, then you haven't got the images to back up what you've put down. I don't know. We'd stand where you guys would stand as opposed to where we would stand. So that's why we have to do it. But I'm sure that the you know, your governing body should have some information about that on for you guys, what needs to be happening and how you work around it and how you do it. And it's pretty clear for us. We have to document images. We have to have all those, you know, for CQC registration, have all the policies in place. And there's a lot of them. I'm not going to lie, there's a lot of them. And it's just, it is a bit of a ball ache. But you know, it's something that needs to be done. Yeah, so I don't know where it stands with what you guys, I imagine it's different. If you're using it to support your diagnosis, I think then, you know, I think that's fine. But I think the grey area comes is when you start documenting and writing a report on an ultrasound image, you know, where you stand there. I don't know. So you'd have to probably seek some guidance on that.
Okay, thank you, chaps. I'm going to step out of that minefield and we're going to go back to the world of the interesting world of clinical questions. But thank you for your input on that. Although I will just say quickly, I mean, you know, the monetizing, you know, when I'm talking to practitioners who are looking to take on, you know, there's that holistic, well, that's not too fuzzy a word to use, where even if you're not charging for something specific, that in your practice, it's one hell of a thing to have in your practice to back up your, you know,
yeah, you can get really bogged down in all the, you know, if you can really overthink it, you know, and actually just keep it simple, you know, use it initially to reinforce your clinical practice and what you're going to do anyway with that patient, you know, then
certainly when you're starting out.
Yeah, and then once you get more confident, you know, because we are all starting, so, you know, you're not going to be held to ransom, just use it to support your clinical diagnosis anyway.
But one thing it does,
you get more and more confident. I mean, it is absolutely great. There's no right or wrong. You know, for us, it is a clinical tool. You know, it's just like your Doppler machine. You know, nobody's going to ask you to record the sound that came out of the Doppler machine and, you know, prove that it was, you know, biphasic or triphasic or whatever. Yeah, so it's a similar thing. It's a clinical tool. You're using it as with your own clinical judgment. Nobody else will see or report in quite the same way that you will. So just be confident and just go at your own level. So, you know, it's not like you're going to be suddenly writing reports and sending them to doctors and consultants and GPs and stuff. That's Adrian's job. You know, for us, it's to aid and support and speed up our clinical processes, I think. And if you get so good at it that you're very confident that you do think you can go and report and do all that stuff, well, you do need to have a specific qualification then. Yeah, but for doing what you're doing and just getting going, you know, you don't worry about all that stuff. Just keep it simple. Say what you see on the day, record it. You don't necessarily have to keep the image, and just try to use it to support what you do clinically anyway, you know. So it's just a bolt-on, add-on. It just happens to be that you got the scanner in clinic. And I think that would absolve you enough of anything else. You know, we're all learning, you know. You're not going to go to court. Well, I bought an ultrasound scan, and you know, 2 weeks later I had a look at something. You know, well, nobody. You know, I think that would be really unrealistic, and it's unheard of. You know, there's no cases of that. We all have to learn. You know, it's a tool. You got to learn and start somewhere, and you'll make maybe little mistakes along the way. But we're all very experienced clinicians, luckily. So a lot of the stuff you should be able to clinically reason anyway, and then you're just using the ultrasound to justify perhaps what you're doing.
Okay, brilliant. And the other thing to consider with a scanner is guided injections, if you want to talk about monetizing.
Yeah, and you know, it's totally operator dependent. It's about no two people are going to say or see the same thing on the same day. So, you know, don't worry that, you know, you've scanned it that way that day and said so-and-so, and then the next day they've gone to see a sonographer and he said so-and-so. There will never be any comeback, because that's that person's individual independent view at that time of that study. You know, the next day something else could have happened. They could have tripped and fell, or did, you know, God knows what, and it could be a completely different picture. Or it's just that that person on the day had a different machine and a different way of looking at things. So, you know, if I and Adrian looked at the same image, we'd have two different reports.
All righty, brilliant. We will, as I say, thank you. That's great. Okay, back to 1 or 2 clinical questions. I think I've got 1 or 2 coming in. So, in fact, from Sean, thank you, Sean, again. Can you describe what you might see in ultrasound scanning in Sever's disease, calcaneal, or you guys always test me, calcaneal apophysitis?
Well done, mate. Very good.
Did I get that right?
Yeah.
You know what I mean? He plays for Italy, didn't he?
Yeah. Calcaneal apophysitis. Yeah, I've got a nice slide of a couple of those things, but essentially where you'd see a nice regular bone at the back of your heel, you know, and the Achilles tendon attaching on top of that, you'll generally see a big extra lump of calcific lump. You know, it was a big spurry thing. Yeah, and sometimes you get multiple little segments of them. Little kind of, it looks like a big spur with little breaks off it. Very different. Sometimes you get small ones, big ones. Sometimes I found it's hard to actually see them. I've looked at some. You know, obviously you look at them and they've got a big haglins on the back, but when you kind of scan over it, it doesn't look too abnormal. And you kind of think, well, you know, you're just seeing the back of a regular shape of the bone, but you're not necessarily, you know, going to see a big humpback whale on there. And other times you just see big chunks and blobs of calcium. You can't miss it, you know. You just keep looking at normal Achilles tendon. Just keep looking at your own Achilles tendon and insertion at the calc, and, you know, just keep that in mind, that it should be nice, clean, straight lines and nice, clean, straight curves. And once you've got that picture set in your head, it's so easy to see when it's not that and it's something else. It's actually a really nice study to do at the back of the heel, because it's very straightforward. There's very little soft tissue around there. Haglins or Severs, it's, you know, you're going to see similar sort of changes in both. They're just going to have slightly different presentations, but essentially you're going to see the same sort of thing. Bit of, you know, it tends to be part and parcel. You'll get some calcific changes, some thickening of the tendon, maybe some tendinopathic features to it. Sometimes the Severs bit is just, you know, calcific changes within the actual tendocalcaneal junction.
Okay. Actually,
yeah, it's very obvious to see. It looks like blooming mountain peaks and ranges, and, you know.
Can you see Maurizio's question there? You're talking about Haglund's deformity or Sever's disease. So does that answer your question, Maurizio? I hope I got your name right, by the way.
Yeah, I mean, the Sever's disease is
kids.
With the growth plates with the kids, isn't it?
Hi. No, the question is based on basically what you're talking about is, I think what I understood was you were talking about the Haglund's disease, which is a bony extrusion which forms and calcifies. But Sever's disease being an apophysitis, which you see in kids, normally that hasn't yet occurred. You've got a break in the growth plate.
Yeah, you can see the irregularity around the growth plates. Yeah, yeah, you're right. You do see the growth plates. You can see them very nicely.
Yeah, it looks like a fracture in actual fact, but it's obviously not.
Yeah, just not joined. Yeah.
The thing is that you're going to get a lot of more areas of hypoechoic tissue, or areas where you're going to get less or more echoic areas. And this is very difficult to identify on the ultrasound scan, Sever's disease. Very difficult.
What do you think of that, Adrian?
Yeah, I mean, we don't scan kids at all hardly anyway, so that's probably why I don't come across it. But yeah, I've seen certainly pictures of it. It just looks like it looks like a fracture at the back of the heel, and it looks like he got like a chunk or bit eaten out of the back of the heel. And yeah, I mean it's. I mean, you can pick it up on ultrasound, but it's difficult.
Yeah, I think your clinical assessment is the most important thing here. What the patient experiences clinically, and then the ultrasound scan can help a little bit, but I don't think it's going to give you a diagnosis. You're not going to be able to diagnose Sever's disease with ultrasound scanning.
No, we don't look at much.
Brilliant, thank you. Thanks for contribution.
Okay.
Did we answer Mark's question? Will you see that? Did you answer that, Adrian?
Which one was that, sorry?
Will you see that in kids? So
yeah, I mean you will see it. I mean it looks like a fracture, but you know it's one of those you just got to be careful with and use your clinical judgment and things as well.
Okay, brilliant, thank you. I'm conscious of the time. It's 9 o'clock. We're all happy to keep going. There are 2 or 3 more questions to coming in, and on the same topic from Martin. Thank you, Martin. What else would it be in a teenage active kid with sporty interests?
Oh, you mean what the appearance of Sever's disease?
Yes, so is that right, Martin?
The microphone off. I wrote it wrong. Yeah, exactly. If you look at the clinical condition of Sever's disease, then frankly, what else is it going to be? Is functional equinus. You'll have usually the boys who just have a growth spurt who are very sporty, usually overtly sporty, and then okay, good sometimes of course, but mainly boys the ones I've seen. And you scan it and you're going to see it as a Sever's, aren't you? You're not going to see what else is it going to be at that age? Yeah,
sure. Yeah.
There isn't going to be anything else.
Like similar to Osgood-Schlatter's, I suppose, at the
Osgood-Schlatter's the knee. Yeah, this is in the knee.
Yeah, no, I'm saying it's a similar sort of.
Oh yeah. It's an app pulling at the top here. I'll give you that, but it's I got a few tips my son had, but as well, so I remember treating it quite acutely.
Friday. Thank you. Great. Thank you. Thank you, Martin. Mark says yes, answered. So thank you. That's great. Let me just make sure I haven't missed any because I've whizzed down a couple. If anyone is going to do the PG cert, you'll really need Adrian as your mentor. The best. Quite agree. Yeah, thank you, Paula. That's great. Absolutely right.
Oh, Paula, thank you.
Actually, on the mentor groups, obviously we're looking at Celtic. We're looking to put together the mentor groups. That's some of the assistance we want to offer for our users. So we'll have users for that soon, and we're looking at ways, and we're going to do a trial run. So if there's any out there that want to be on the dummy run for us, we're going to put a small group together. So don't be offended if you don't get. But we are looking. We want to see if we can do it because maybe the mentor workshops aren't going to happen anytime soon. So we are looking to see if we can make it work on virtually. So stay in touch with me, anybody who's interested in that, because I think the mentor groups are really important. This has come up before. One of the toughest things for people, getting into scanning is having a mentor. But we're going to see if we can fill a bit of a gap there. And I know Adrian's already doing already doing some great work and put in that kind of service, if you will, if that's the right phrase, together. So you're absolutely right, Paula. Yeah, who better than Adrian? Maybe Abid a close second. Or as good, I don't know. But anyway, good mentors right here in front of us. So you're absolutely right. Let me go back down. We've answered those questions. We've answered those.
One here, I think, by Chris. Would you be able to show some finger pulley injuries?
Yeah.
And how the tendon gaps in the position? Yeah, sure. I mean, you can certainly see the pulleys, the cruciform ones that you don't see very well, but certainly the A1, 2, 3, 5, and pulleys you see very well on ultrasound. So we can show those.
Do those. We'll cover those in a future session. Brilliant. Thank you. Okay. Well, here let's share some information. Martin, have a look at James' presentation from Podopeds conference last year. You'd be surprised. There you are. Okay. Well, we'll leave that one for offline. But thank you, Mark. Thank you. All good to share. Anna's going to be in. Right, one from Sam to both, and anyone who wants to answer actually to a scanner. Background noise there. To a scanner starting out, what terminology or landmarks would you suggest learning focusing on the most detail for your respective disciplines?
Plantar fascia. Yeah, plantar fascia and Achilles, I'd probably say, I think is the easiest one to help to get your probe orientation and the easiest one to visualize to begin with, I think.
Right. Yeah, I agree.
Yeah, you get really nice images of the plantar fascia and the Achilles tendon, and be able to move it, transverse and have a look up and down and through it, and go from insertion to attachment. Once you can clock that, and it's easy to do to yourself, it's not difficult to get that going around your own foot and ankle, so you can really practice on yourself. You don't need a patient necessarily, and it's just getting getting the grip right, getting the pressure right, and getting the right angles. So I think that's a good one. Best one I'd go to start with.
Okay, you're still okay for time. I've got another question. Styloid process, peroneus brevis insertion. The particular person says they have trouble tracking around the edge. Any tips around that? Any suggestions? So in the peroneus insertion.
The lateral malleolus. Go around the lateral malleolus at the insertion on the 5th. Right.
Styloid process, peroneus brevis insertion.
Okay, well, I think they're talking probably around the malleolus because it's
okay. Beg your pardon. Right.
Going around. Well, usually, I tend to probably best to compromise half of your probe width, and it's better to demonstrate this, to be honest.
Okay.
But if you compromise half of your probe width and just follow the bottom half of your probe around the edge. Then sometimes that can be quite good. Alternatively, you just whack a load of gel around the ankle and sit your probe in the gel. Don't touch the foot or the ankle at all. Just keep the probe sat in the gel, and you move around the malleolus. You've got a beautiful image all the way around because it acts as a standoff window around the whole ankle, so you can try that as well. But
can I show you a little demo how I do it? Oh, sorry, Adrian interrupted.
No, I was just say it's easier to do demonstrating this.
Yeah, I don't know if you can make it out because it's so white, but here's your styloid. So what I usually do is start with my little finger. My little finger is the guide. So if I'm not quite sure it is, I just follow the length of the metatarsal. So I'm starting at the base of give you a bit of blue background there, shall I? Yeah, I just run my finger along it until I feel I've hit the tubercle. Okay, so from there, I know where the tendon is. And if I go linear to it, I'm not going to see it. I need to angle that up between your lateral malleolus and the styloid. So look at that diagonal line there, and you're pretty much on it then. So eyeball the bottom of the fibula, and eyeball the styloid, or palpate for it. And that's exactly then where your probe goes, about there. So you might just find you're quite on it on one point, but not on the other. So get the very, very tip of your probe onto the bony process. Yeah, make sure you can see that well. And then make sure the other end of the probe is on the corner tip of it. And then if you don't think you're quite on it, from there, you just need to rotate very slightly. See that little movement? Yeah, and it's ever so slight, you know, much more slight than that. But essentially, it's a diagonal line between those two bony prominences. Hope that helps.
Brilliant. Thank you, Abid. That's great. And we can tag that into one of our upcoming webinars as well, can't we? When we can, maybe you can scan it.
Absolutely, yeah.
Brilliant. Thank you. Great. Listen, I think that's been amazing. I think that's been brilliant. Thank you very much.
Yeah, loads of fun. Thanks for the interactivity. That was great. And you know, if we do another one, let's maybe plan some more in and get a bit more interactive. So maybe we should do a bring your pick session, because you will, once you start scanning, you'll see all sorts of weird stuff, and you might initially not be sure exactly what you're seeing. So just try and take a couple of good views for us and bring them along to the next party, and let's have a chat about them. You know, we'll probably learn just as much as from doing that as you guys will.